Good morning, ladies and gentlemen. First of all, also on behalf of my co-authors, I would like to thank the scientific committee for giving us the opportunity to present to you the results on our study, Pulmonary Effects of Transition from Invasive to Non-Invasive Respiratory Support and Positional Change in Preterm Infants. I have nothing to disclose. Respiratory failure is common in preterm infants, and mechanical ventilation is still necessary in about 70% of the infants below 1,500 grams at some point during admission. The duration of mechanical ventilation is associated with the development of bronchopulmonary dysplasia, and therefore it's important to extubate these children as soon as lung function has improved. However, predicting sufficiency of breathing after extubation is difficult, and we still see extubation failure rates of about 20 to 30% within 48 hours. The reason for this is unknown, but an association with suboptimal lung volume after extubation has been proposed. However, the exact changes in lung volume following transition from invasive to non-invasive respiratory support are largely unknown. We know that lung volume is affected by many factors, amongst which positioning plays an important role, and prone positioning can improve lung volume in preterm infants. Therefore, infants are often placed in prone position after extubation for stabilization. However, the exact impact of such prone positioning in the first phase after extubation has not been investigated. We have therefore conducted a study with the following research questions. First, does extubation lead to changes in end-expiratory lung volume, tidal volume or respiratory rate, or ventilation distribution? And secondly, is there an additional effect of the positional change on these parameters shortly after extubation? We have conducted an observational study in preterm infants with respiratory distress syndrome treated with high-frequency ventilation. We have monitored lung volume using electrical impedance tomography, a non-invasive tool based on tissue resistance differences, as shown on the right-hand side. This image shows you the principles of EIT, which I will briefly introduce. 16 electrodes are placed on the circumference of the thorax, and a small rotating current is used to calculate differences in tissue resistance or impedance. This generates an illustrative image of impedance changes over time, with red signifying large and blue signifying small impedance changes. Since air has high resistance, these changes in impedance correlate well to actual changes in aeration, and thus showing you the right and left lung. So this image gives you information about the regional differences of lung volume throughout the lungs. Impedance can also be quantified and shown as an image shown below, where you can see an increase in impedance after an increase in continuous descending pressure on mechanical ventilation. This gives you information about end-expiratory lung volume and tidal volume. We have used EIT to continuously registrate lung volume, starting before extubation on high-frequency ventilation, which some call CPAP with a wiggle, and for 2 minutes the oscillations were stopped, leaving endotracheal CPAP as a support for spontaneous breathing. The infants were extubated in supine position and transferred to nasal CPAP, and lung volume was registered for again 10 minutes. Then the infants were switched from supine to prone position, and lung volume was registered using EIT for a final 10 minutes. As mentioned, the outcomes of our study were end-expiratory lung volume, spontaneous tidal volume and breathing frequency, transcutaneous CO2 levels, and ventilation distribution of the spontaneous tidal volume. We have included 20 preterm infants with respiratory distress syndrome treated with high-frequency ventilation. The mean gestational age was about 29 weeks and the mean birth weight of about 1,100 grams. We have extubated the children from a continuous descending pressure of 8 centimeters of water and transferred them to nasal CPAP PEEP 6 centimeters of water. And no differences in oxygen need before or after extubation were observed. This graph shows the changes in global end-expiratory lung volume, with on the x-axis the 3 stages, on the left-hand side before extubation on endotracheal CPAP, then after extubation on nasal CPAP in both supine and prone position. And on the y-axis you can see the end-expiratory lung volume changes in arbitrary units per kilo. As you can see, there was no reduction and even a small but significant increase in end-expiratory lung volume after extubation, as you can see in the middle. After switching from supine to prone position, we see a substantial increase in end-expiratory lung volume. These changes can be divided into both ventral and dorsal regions, and when you look at this graph, you can see that the increase in end-expiratory lung volume is mostly located in the dorsal regions. I will talk you through this complex slide showing the ventilatory parameters, tidal volume, breathing frequency, and transcutaneous carbon dioxide levels, with on the left-hand side endotracheal CPAP before extubation, then nasal CPAP after extubation in both supine and prone position. And as you can see, after extubation, we see a significant increase in tidal volume at a stable respiratory rate. And after switching from supine to prone position, we can see that the tidal volume remains stable, but the breathing frequency significantly decreased. The transcutaneous carbon dioxide levels remained stable throughout the study. This slide shows you the ventilation distribution, which I will briefly explain. On the right-hand side, you can again see the impedance change image going from ventral to dorsal. The slide can be divided into 32 slices, going from 0% ventral to 100% dorsal. And this corresponds to the x-axis of the graph shown on the left-hand side, going from the left 0% ventral to the right 100% dorsal. On the y-axis, you can see the impedance in percentages. So if you take, for instance, a slice at about a third of this cross-section, you can find the impedance value at about 30% in the graph. So this graph shows you the ventilation distribution of the spontaneous tidal volume, so different from end-expiratory lung volume, before extubation for endotracheal CPAP. You can see that the curve is pyramid-shaped with a slight tendency of the peak towards the dorsal regions. After extubation, we saw no differences in ventilation distribution. However, when we switched from supine to prone position, we saw a significant difference with a more homogeneous distribution of ventilation with a slight tendency towards the ventral regions. So to summarize, after extubation, we have seen a small increase in end-expiratory lung volume with an increase in tidal volume. We have not seen any changes in ventilation distribution or respiratory rate. After the positional change, we see a further increase in end-expiratory lung volume, mostly located in the dorsal regions, and we have seen a decreased respiratory rate at a stable tidal volume, and tidal ventilation of the spontaneous tidal volume was more homogeneously distributed over the ventral and dorsal lung regions. So in conclusion, we can say that infants on non-invasive respiratory support can maintain and even slightly enlarge their lung volume after extubation at a lower descending pressure than on invasive mechanical ventilation. And this could possibly be explained by a regained control of the upper airways after removing the endotracheal tube. Secondly, these effects are augmented by placing infants in prone position, and these results seem to suggest that prone positioning is a preferable placement after extubation. Thank you for your attention. I'd be happy to